Dr. Michael P. Dentato is an associate professor in the School of Social Work at Loyola University, Chicago, where he also serves as co-director of the Center for Field Innovation, Strategy, and Training, and vice chair of Loyola University Chicago's Faculty Council. In addition to his teaching, research, and scholarship interests, Dr. Dentato has over 20 years of community-based and consultant experience, including clinical, administrative, and policy work throughout his tenure in New York City, Miami, and Chicago. Dr. Dentato is the editor of Social Work Practice with the LGBTQ Community, The Intersection of History, Health, Mental Health, and Policy Factors, published by Oxford University Press, with a second edition forthcoming in 2021. And with that, I'll go ahead and hand it over to Dr. Dentato.
Thanks so much, Sarah, and a warm welcome to all of you joining us today. I'm excited to chat about the SBIRT model and substance use challenges among LGBTQ+ populations. Just a quick thank you to both Lindsay and Sarah and Marlene and colleagues at the center for all the ongoing hard work that they've been doing. So thanks again for joining us today. Our objectives are to talk briefly about current trends in alcohol and substance use among members of the LGBTQ+ community, explore risk and resilience factors associated with substance use disorders and the framework of minority stress theory, discuss the need for universal screening across diverse practice settings and use of the SBIRT model, and explore the applicability for using the SBIRT model across diverse segments of the LGBTQ+ community, including youth, older adults, transgender, gender diverse populations. So we'll start with a little bit of background. This slide illustrates how there is use of alcohol, tobacco, and marijuana in much greater proportions with regard to past month substance use among those aged 12 and over, with regard to findings from the 2018 National Survey on Drug Use and Health. In the middle circle, you'll see the significant difference. The darker blue shaded represents past month substance use, about 165 million, or 60% of those in the survey, compared to 40% with no past month use, about 109 or so million people. What's interesting over on the right side of the screen is you can see that there are clearly some ongoing challenges also with regard to prescription drug use, with regard to cocaine use, meth use, inhalant use, and heroin as well. But with regard to this study from SAMHSA, which is a representative sample, you clearly see the majority having challenges with alcohol, tobacco, and marijuana use. So I think it's important to split the difference and talk a little bit about sexual orientation compared to gender identity and ensure that we're not conflating substance use as it relates to those with regard to the LGB population compared to the TQ+ populations. I think it's also important to not make assumptions that all LGBTQ+ people are at risk for alcohol or substance use, right? So it's important to understand in your assessment that folks may be navigating substance use or alcohol use based on a variety of issues that may be related to health or mental health or the combination of both and have nothing to do with their sexual orientation or gender identity. So with that said, compared to the heterosexual community, LGB individuals reported greater alcohol use, recreational substance use, and tobacco smoking in some of the work done by Brandstorm and Pachankis. And in 2019, again, back to the national survey that I was just talking about, there were significant increases in methamphetamine use among LGB adults aged 26 and older when compared to previous surveys in 2016 and 2017. With regard to race and with regard to age, significant disparities in smoking, excess alcohol use, and marijuana use was found among LGB women in greater magnitude, specifically for Black and Hispanic LGB women compared to white LGB women. So again, just underscoring some of the intersectionality pieces with regard to race and gender and alcohol and substance use. With regard to youth, the Trevor Project research brief that came out in 2020 noted rates of past 30-day alcohol use were 25% higher among LGB high schoolers and 18% higher among those 18 to 25 compared to their straight counterparts. And disparities for recent marijuana use were similar among LGB high school students, 62% higher, and young adults ages 18 to 25, 59% higher compared to their straight peers. With regard to transgender, gender diverse, queer plus communities, according to the most recent US transgender survey of over 27,000 respondents, about 1/4 reported using marijuana within the past month, compared to 8% of the general US population. 29% reported illicit substance use, marijuana consumption, and or non-medical prescription drug use in the past month, which was nearly three times the rate of those within the general population. And then with regard to race, ethnicity, you'll see some of the differences in that last comment there with regard to Latino, Latina, Middle Eastern, and Black, more likely to report binge drinking among the TQ plus community, while white and Asian respondents reported lower levels. A little bit on the non-binary community. A study done in Massachusetts, about 450 or so participants, looked at non-binary and binary transgender adults, finding that non-binary adults were more likely to exhibit hazardous levels of drinking compared to binary transgender adults. Also noting in this survey that non-binary respondents skewed younger than the binary respondents. So it is possible that the discrepancy in hazardous drinking can be attributed to developmental life stage rather than to gender or gender identity of the participant. Again, hearkening back to what I started with, not making assumptions or pathologizing alcohol or substance use and assuming that everyone in the LGBTQ plus community is using, has used, or is at risk for using. Minority stress theory helps us understand a little bit why sexual and gender minority populations are at heightened risk for both health and mental health challenges throughout the lifespan. And clearly, the work that Elon Meyer did to adapt the model is important to help us understand that chronic and acute prejudice-related events could increase minority stressors, as well as expectation of minority stress and the vigilance that the expectation requires, right? Navigating stigma and throughout one experience, throughout the lifespan of experiences of stigma. The internalization of negative societal attitudes, internalized homophobia, internalized transphobia, biphobia, and so on, and concealment of one's sexual orientation, and I'll add, when possible, gender identity, while also discussing the role of coping and social supports. So to just expand a little bit upon minority stress theory, progress is being made to understand intersectional factors, specifically with regard to looking at depression, suicidality, and substance use at layers of almost a double or triple level of discrimination because one is a bisexual, an older LGBT adult, an ethnic minority, LGBT individual, or a transgender adult as well. The last comment on this slide, I think, is one of the most important, again, to ensure that we are looking from a strengths perspective and a resilience-based framework when we think about the role that coping, adaptation, and resilience play with regard to ameliorating the challenges of minority stress, and that both at the individual and community level, that resilience is part of a continuum where it remains important to know evidence of when any type of minority stressors may be arising. So again, thinking forward, moving from a pathologizing framework to a resilience framework of care, when we're thinking about implementing alcohol and substance use screening, assessment, and treatment with LGBTQ plus populations. But again, we have to be ready, and we have to be culturally humble, and we have to use affirming models of practice. So the last couple of comments on this slide note that in the Williams and Fish study in 2020, over 11,000 mental health facilities and 13,000 substance use facilities found limited availability of culturally competent mental health and substance abuse treatment, despite a well-documented need among LGBTQ populations. And in a small study that I did back in 2017, students and alumni clearly often do not feel adequately prepared to practice with LGBT populations affected by substance use. So what's the impact that that has on the need for more classroom-based and postgraduate trainings with regard to effectively preparing the workforce, as well as understanding culturally affirming and humble practices as well. So I'm going to talk about the SBIRT model and introduce you to the model for those of you that are not familiar with it, and also talk about affirming LGBTQ plus practice. So SAMHSA defines SBIRT as a comprehensive integrated public health approach to the delivery of early intervention and treatment services for those with substance use disorders, as well as those who are at risk for developing them. That's where SBIRT really is key, catching people early before they're more advanced with regard to their alcohol or substance use challenges. So the model can identify problematic substance use quickly. It can be used in a wide variety of settings, and it is increasingly used in behavioral and medical treatment in both prevention and early intervention, but still new for many practitioners. It was used widely, predominantly in the nursing community and other professions such as medicine and social work and psychology and dentistry. Pharmacology have been slowly catching on to the importance of the use of this model. So the S in SBIRT stands for screening, the BI is the brief intervention, and the referral to treatment is the RT. So the screening is a universal screening to quickly identify unhealthy use and severity of use. Depending upon the results from the screening, you may or may not move into the brief intervention, and you may or may not move into the referral to treatment. We'll talk a little bit more about that as I move forward today. The brief intervention is based in motivational interviewing skills and consciousness raising and awareness raising with regard to those that are at risky or problematic use, and providing affirmation for those that are not using or using at lower levels, giving feedback about use and also providing education to enhance one's motivation. And a brief intervention can be a one-time interaction. It can be as quick as 5 to 10 minutes, or it can be several interactions and happen over weeks of time, depending upon the amount of time you have with your client or patient. Based on the results of the brief intervention, you may or may not need to give a referral to treatment. And a referral to treatment can include a linkage, warm handoff to specialty care for those at higher risk for substance use disorders. And remember that referral to treatment is probably going to be about 10% of those individuals screened. So we're not talking a high rate. You may need to do a full assessment and treatment for those that have substance use disorders, or again, it can be a very brief treatment or referral to specialty alcohol and drug treatment, a 12-step group, and so on. Bottom line is that the SBIRT model is based on stages of change and motivational interviewing. So another way to look at the process, the top box represents the screening, and based on the results of the screening, a client or patient will be anywhere from low risk to moderate to high, to severe risk, or the level of dependency. Depending upon the results of the screening, if they are low risk, there's really no further intervention that may be needed at that time. If they're at high risk, you may need to refer them to a brief treatment, or clearly with regard to severe risk or dependency, you may have to refer to a specialty treatment program or service. A good majority of clients and patients may be at the moderate risk level, which is the second row, in which you would engage in the more full brief intervention process. So in order to make the SBIRT model affirming, it's important that we do some self-reflection, that we are raising our own consciousness and self-awareness, navigating our own homophobia, biphobia, trans queerphobia, cissexism, heteronormativity, and so on, because we have to start with ourselves in order to be affirming practitioners to members of the LGBTQ plus community. You will see as we move forward that the screening tools often use binary language, so they must be modified to ensure that they are including your client's chosen pronouns, names, and so on. Ensure that all stages of the model meet the unique needs of your LGBTQ plus clients. The lens of motivational interviewing is absolutely essential during brief interventions or referrals, and hopefully you're making those referrals to LGBTQ plus affirming providers, and you have that knowledge base in your resources. What we've learned clearly over the past year and a half is the important role of navigating and using the screening and brief intervention and referral to treatment process online, and the importance of telebehavioral health, so that we are still learning, and the literature and research is still evolving about the effectiveness of using the SBIRT model online in order to widen access to LGBTQ plus clients. Think about peer-based approaches that we know can be incredibly well effective for both screenings and brief interventions, so that youth are working with youth, older adults are working with older adults, or members of the trans and gender diverse community are working with one another to go through the screening tools or the brief intervention, and you're training them in a peer-based model to do so. Thinking beyond traditional settings, SBIRT is typically used in schools and health clinics and medical-based settings. To think about using the SBIRT model in a bar, a club, at a ball, or a non-medical setting could increase access to screenings and use of the model and connect someone to care early on. Asking permission to screen, to provide the screening results, and always using a person-first approach is important with affirming LGBTQ plus SBIRT. And mistakes are going to happen. Acknowledge your mistakes, apologize, work actively to correct your own attitudes, behaviors, language, and so on, especially if it comes to misgendering or misnaming one of your clients or patients. So in summary, the model can be used effectively across a variety of settings to detect risky and problematic alcohol or substance use early on. The model aims to expand services for individuals engaged in risky behavior or early stage substance use involvement. SBIRT can enable effective intervention strategies to prevent longer-term problems, and early identification of problems can lead to health-related cost savings over time. SBIRT can be modified to be LGBTQ plus affirming, and there's a link at the bottom for more information about SBIRT and the SBIRT model, in addition to other resources on the slide deck. There's a series of different websites as well, and I'm sure that my colleagues at the center will give you access to these links. So let's move into the screening and talk a little bit more about that. So universal screening can detect health problems related to at-risk alcohol use and substance use at an early stage before they result in more serious disease or other health problems. Universal screening can also detect alcohol and substance use patterns that can potentially increase further injury or illness risks with regard to one's health and mental health. It can provide time to intervene and educate about at-risk alcohol or other substance use. And it underscores that research has shown approximately 90% of substance use disorders continue to go untreated. So here's what it looks like. A pre-screening can be as simple as looking at the left side of your screen, on the left side of the slide, and asking the question, are you currently in recovery for alcohol or substance use? If the client or patient says no or checks no on the pre-screening, right, you already kind of understand where the conversation may potentially be going. Now, again, I apologize for the heteronormative kind of cisgendered language, but I'm going to move forward acknowledging some of the deficits in the model as well, and the need to change some of this too. So for men, how many times in the past year have you had 5 or more drinks in a day? If they say none, right, you check none. If they have 1 or more, check 1 or more. Then you might want to ask a little bit more about how frequently they're drinking. Similar to women, how many times in the past year you've had 4 or more drinks in a day? None, 1 or more. You want to follow that with a quick pre-screen that talks about substance use, and that can include everything from methamphetamine to cannabis, inhalants, tranquilizers, barbiturates, and so on. You want to make sure that your client and patient understand what drugs mean or what substance use means, widely defined, and asking the same pre-screening question. How many times in the past year have you used a recreational drug or a prescription medication for non-medical reasons? So if the pre-screening answers are all negative, they're not drinking in excess, they're not using substances in excess, you might want to affirm what they are doing, right, in taking care of themselves or navigating or monitoring their intake compared to those that are using more. If the pre-screen is positive, so for example, again, if the male client said they are having 5 or more drinks a day, every single day, that's probably a pretty big warning sign that you want to move into a full screen. On the other side of the slide, you'll see some examples of screening tools that I'm going to walk you through briefly that are used for alcohol, for substance use, and for those for youth, which is the CRAFT tool. So we'll go through the audit for alcohol, the DAST for drug abuse, and then the CRAFT for those for individuals under the age of 21. That includes both alcohol and drug use. The audit tool is the Alcohol Use Disorders Identification Test. It's 10 questions. It can be self-administered, or you can ask the questions in an interview format. It can also be used on an iPad to address recent alcohol use, alcohol dependent symptoms, and alcohol-related problems. And it was developed by the World Health Organization. And here it is. Here's what it looks like. For the sake of time, I'm not going to be able to go through all of these today, but I'll give some examples. So the first question is, how often do you have a drink containing alcohol? Client says never, then you put the score of 0 over on the right-hand side. If they say daily, you put the score of 6 on the right-hand side. So you kind of see where this is going. As you go through the questions, the more zeros you have, the more zeros and ones you have, the lower risk the client or patient is for having an alcohol use disorder. If the client is having more along the 4, 5, and 6 line, right, the score is obviously going to be higher. So I'll give another example. Number 7, how often during the past year have you had a feeling of guilt or remorse after drinking? If they say daily or almost daily, so that's a 4, then you put a 4 in the score column. You sum up the scores, and depending upon the score, if they score between 0 and 7, I'm in zone 1, which is going to be about 40% of your clients and patients for screening and feedback. That's low risk. That's considered low risk. So again, you want to reinforce what they're currently doing, reinforce the behaviors, right? Talk to them a little bit about how they continue to moderate situations in which they may be using alcohol or be exposed to substances. Compared to zone 2, so those that score 8 to 15 on the audit, you want to engage in the brief intervention. Those that score between 16 to 19, considered harmful use. You want to do some ongoing monitoring with the client or patient and potentially move to a referral for a brief outpatient treatment program. And for those scoring 20 or higher on the audit, you probably want to move into the referral to treatment stage of the SBIRT model for a more extensive evaluation, treatment, and care. And that would be about 5% of those based on current research. The second tool I'm going to introduce you to is the DAST-10, which is the drug abuse screening test. Consists of screening questions for at-risk substance use. The strengths, it is sensitive to be used for at-risk drug use, but it doesn't include alcohol use. So you may have to use the audit and the DAST-10 to look at alcohol and substance use for each of your clients. Similar to what I talked about just a few moments ago on the audit tool, with regard to the DAST, the more a client or patient is responding yes, the higher the likelihood is you're going to have a client move into the brief intervention stage of the model compared to no. So question 1, have you used drugs other than those required for medical reasons? No. Do you abuse more than one drug at a time? No. Are you unable to stop using drugs when you want to? No. So again, the client continues answering no. You'll see what on the next screen, how to evaluate the responses from the DAST-10 tool in order to make a determination about the brief intervention stage. So again, if the score on the DAST-10 is 0, then basically all no's. Then the degree of problems related to drug use is no problems reported. There's really no suggested action to be done at that time other than to reinforce their current behaviors. Compared to, I'll move to a 3 to 5, being a moderate level, you might want to continue doing further investigation, move them right into the brief intervention stage of the SBIRT model, compared to those at higher risk, where you're probably going to move from the brief intervention to the referral to treatment. The third tool is the CRAFT tool. It's the most popular alcohol and drug use screening tool for youth and adolescents, age 14 to 21. and it is a validated screening tool as well. So it's important not to make any variations from the language on the tool, actually with any of the tools, quite frankly. I also forgot to mention that the tools are all free. They're all available on SAMHSA's websites and in some of the resource links I've given you, and they're also available in a variety of languages as well. So part A, the first part of the craft tool, is to ask the youth or adolescent if during the past year, did they drink any alcohol, more than a few sips, smoke any marijuana or hash, or use anything else to get high, and anything else can be illegal drugs, over-the-counter prescription drugs, or anything else that is sniffed or huffed and so on. If the youth answers no to all questions on this, A1, A2, and A3, then you want to stop and reinforce their great behavior and what they're doing with regard to their alcohol or substance use or being around alcohol and substance use with their peers. If they answered yes to any of the 3 questions, then you want to move to the part B of the craft. So this is the CRAFFT, and the questions pertain to riding in a car with someone who is high or been using, ever using alcohol or drugs to relax, ever using substances when you're alone, ever forgetting things when you're using, and do your family or friends ever tell you should cut down on your use? Or did they ever get into trouble? So again, depending upon the responses here, if they're answering no's, they're at lower risk, yeses at higher risk for moving into the brief intervention stage. So there's the score. Score of 0 to 1 can indicate there are no problems, minimal challenges or problems, but a score of 2 or more can indicate more significant problems exist in the need for the brief intervention. But the 2+ cutoff score is not a hard or fast rule. With any of these tools, you have to really use your gut level intuition and understanding of the client population in order to make the best determination. So the tool is a tool and a resource, but not the end all and be all. Additional resources. So just before I move into the brief intervention piece, I want to say that just anecdotally, what we've been finding with a bunch of different organizations and schools that we've been training is that the tools are very helpful and very useful in order to engage clients with conversations around alcohol and substance use, and then determine about whether or not you need to move into the brief intervention stage. We have found anecdotally as well that it just depends on your client population about whether or not they're more interested in filling out the form themselves and they're more truthful in doing so versus the intake worker, the social worker, the nurse, or the doctor asking them the questions, or using a technology like an iPad in order to utilize the tools. So again, you know your client population's best, you know your settings best, so you can make that determination. So based off the results of the screening tools, you may or may not need to move into a brief intervention. And a brief intervention is a behavioral change strategy that's short in duration, aimed at helping an individual prevent, reduce, or stop problematic usage or behavior based in motivational interviewing. And motivational interviewing, for those of you that are not familiar with it, is a method of communication that's focused on an individual's concerns, working to enhance their internal desire to change, their willingness and ability to do so, and explore and resolve conflicting or coexisting or opposing feelings about that change. Now, remember, although most screenings will fall within the low to moderate risk, all clients and patients will potentially benefit from a brief intervention or a discussion based in motivational interviewing. It's important and essential that you provide the brief intervention immediately following the screening results. Don't wait until the next session or that you may have with your client or patient. And again, a brief intervention can be anywhere from a few minutes to several sessions. And the goal of the brief intervention is to help individuals arrive at the reasons for change that will be most influential to them, to create realistic plans for that change, and to monitor steps taken to correct or reinforce the changes. So the steps of a brief intervention include the left-hand side, engagement, talking about pros and cons, asking for permission to give feedback, using the readiness ruler, negotiating an action plan, and summarizing and thanking your client and patient for being present with them during this conversation. And I'll go into each of these a little bit more. What's important with regard to engagement is establishing a rapport with your client, being reflective when you're listing pros and cons, when you're giving feedback, asking permission to give that feedback. I'll talk about the readiness ruler in an upcoming slide and how useful that tool can be. When you're talking about an action plan with them, talk about what the future might look like, what challenges they may encounter, how they can draw upon past coping, adaptation, resilience, or past successes in navigating alcohol or substance use. And again, make sure at the end you're summarizing and thanking them, reinforcing their resilience, giving some resources, providing handouts, thanking them, and scheduling a follow-up if necessary. So key skills, using open-ended questions. We well know if you're asking questions that can be answered by yes or no, many clients will answer yes or no, and it ends the conversation. Being affirming in your language, and again, always making sure that you're using the correct pronouns, the correct name, and the correct LGBTQ plus affirming approach with cultural humility and being self-aware as well. Using reflective listening skills, right? Tell me more about that. It sounds like you've been through a challenging time. Tell me how you got through that. Summarizing, right? So it sounds like what I'm hearing today is A, B, C, and D. Eliciting change talk. So talking to the client specifically about what change could look like or might look like for them, very much based in a harm reduction model perspective. If you're moving in that direction with the client about reducing the amount of alcohol they're drinking or the amount of substances they're using. Asking permission versus giving advice. The SBIRT model and motivational interviewing is not about giving your own advice. So keep that in your own pocket, but ask permission to give some feedback, to give some resources, to give some reflections about what the client is saying. Generating a menu of options is really important, right? Talking to a client about option A versus option B versus option C, so that they don't feel locked into only one option compared to several options. And of course, managing pushback and getting ready for anything with regard to denial or anger or frustration with your clients as well, specifically when it comes to talking about their use. So this is the ruler, and the ruler is a great tool that can be used to assess readiness to change, the importance of making those changes, or their confidence in making specific behavior changes over time. And how this is used is basically you would say to the client, so on a scale of 1 to 10, with regard to your readiness to change your alcohol use, 1 being not ready, 5 or 6 being unsure, and 10 being ready, where are you? The client says 6. So that gives you an opportunity to say, wow, okay, so it sounds like you're unsure about readiness to change your alcohol use. You're not really ready to do so, but you're also not ready to do so as well. So you're kind of in the middle. This is a great place to begin from, especially if you have multiple sessions with a client or patient, because you can always say, when we talked last week about your alcohol use and your readiness to create change in that alcohol use, you were a 6. Where are you this week? Client says 9. Wow, there's been a significant change between last week and this week with regard to readiness. Now, of course, it can go the opposite way too, and they can come in and say a 1. I'm not ready. I don't have a problem. I don't believe there's a problem. So I'm a 1 on the readiness ruler. It's a really wonderful tool. Quite frankly, it can be used for any reason as well with regard to assessing level of depression or co-occurring challenges a client is having. Some additional resources, and I'm going to talk now about the referral to treatment process. So a very small number of your clients will require the level of treatment beyond that which you may be able to provide. Specialty substance abuse treatment may be necessary for some of your clients, but be sure to follow your own organizational and agency policies and best practices for referral to treatment, ensuring again at all times that they are LGBTQ plus affirming, as well as just a small caveat, not assuming that all LGBTQ plus providers are LGBTQ plus affirming, right? That's a large assumption to make, and we have well-documented evidence that some problems exist within LGBTQ plus centers and health providers and so on. So know your providers and understand the landscape before you make that referral if you have to. How you talk about referral to treatment really contributes to the likelihood of success, and no client populations, right? So with regard to confidentiality, with regard to age differences, speaking with youth, parental permission, if you're in a school setting, right, versus older adults in a assisted living facility, and so on. So there's a lot of wide variation about how the referral to treatment process may go. Levels of referral, I talked about this a little bit earlier, based on level of need. They may need immediate medical treatment for detox. They may need a referral to a provider within the substance use disorder treatment system for a more robust assessment, treatment planning, or care. They may need a follow-up conversation with you to continue the brief intervention in a week or so. You may want to reuse the screenings and have them do a new audit or a new DAST or a new craft and compare the two based on 1 week to 2 weeks to 3 weeks. Or you might just want to affirm that what they're doing seems to be going well and okay for them with regard to a low to moderate level of alcohol or substance use, and encourage them, support them, and affirm their good decision making. 8 principles when we think about referrals or handoffs to providers. Make a commitment to the client that you're going to be with them through the process as much as you can, that you will be responsible for referral to that appropriate care and treatment setting or provider. Provide understanding for the client and empathy for the client and the current situation that they're in. Ensure that the client understands the designated and clearly defined roles of you as the social worker or as the nurse or as the principal or the AP from the school, right? Who plays what role? Be present as much as you can, if you can, during the handoff to provide that. Maybe that's online and you and the referral source and the client are all Zooming together versus being in an office. Use common language. Don't complicate language for your clients, and make sure they understand terms and acronyms and so on. Practice the process with a colleague and ensure that you're comfortable with the process. Quite frankly, I would say practice the entire SBIRT model with a colleague. Practice use of the tools with a colleague so that you become more comfortable with them overall. And ensure that you are monitoring, evaluating, and looking for ways in which you can improve upon referrals and handoffs. Types of treatment, again, can range anywhere from outpatient to intensive outpatient treatment and care, partial residential, residential inpatient, detox or stabilization, medication assistant treatment, MAT, or an agency-based program, intervention, 12-step group, or so on. So with regard to considerations for referral to treatment, be clear and specific with regard to your language and the necessity for and process of referral. Consider the individual specific needs and preferences of the LGBTQ plus client that you're working with. Know your delivery system. Again, who are those LGBTQ plus affirming providers and who are not. Arrange referrals to other professionals, agencies, community programs, support groups, other appropriate resources to meet the client's needs in whatever way possible. 2 key things with regard to referral to treatment. Do not ever underestimate the importance of interprofessional relationships, and make a conscious effort to build strong relationships across the professions. A couple of ways that we've been looking at implementing the SBIRT model, and specifically some of the work that I've done at Loyola, is in interprofessional teams in which we have a medical student, a nursing student, and a social work student go through the screening, brief intervention, and referral to treatment process and play different roles in that process with the client. So do not ever underestimate the importance of interprofessional relationships or interprofessional models of practice, specifically when using the SBIRT model. SAMHSA has a wonderful treatment locator for those of you located within the US. They also have a national helpline that you can call for confidential, free, 24/7 information available both in English and Spanish, and especially can help if the client is not insured or underinsured on a state-by-state basis to look at resources available to them. So that brings us to the end of our presentation today. And I just want to summarize and say that, again, some, not all, LGBTQ plus individuals may be at heightened risk for a multitude of stressors, that may be defined or described or understood by minority stress theory and models that could exacerbate or promote unhealthy habits, from alcohol use to smoking cigarettes or marijuana to substance use, and potentially related mental health challenges ranging from depression to suicidality or co-occurring challenges for a client. The SBIRT model can be adapted, can be modified, can be made LGBTQ plus affirming, and used widely across practice settings to assess for early intervention associated with alcohol or substance use problems, and that affirming practice really matters with our LGBTQ plus clients and must be attended to and utilized by both health and mental health practitioners to ensure effective treatment and care. So thanks for attending today's webinar on the SBIRT model, assessing alcohol and substance use among LGBTQ plus populations. My contact information is on this slide and my email address is there. I'm happy to continue this conversation with you. I know we have about 10 or so minutes to chat, or I can respond to questions that you've been posting in the chat box. And at this point, I'm going to turn things back to Sarah.
Thank you so much, Michael. That was very informative. Really appreciate it. We do have a few questions here as well as a comment. So for number of drinks, when you're assessing this, do you follow the guidelines for their sex assigned at birth since the risks are biological?
It's a great question. And I think that I'm going to respond to saying that know thy client and know thy client population. So I'm not going to say yes, that you should make the assumption that the sex assigned at birth is the one that should determine the drinking or the drinking habits, right? So I think that's a yes and or but response. And I know that's not a clear response, but I don't want to assume that we should always look at a trans or non-binary or a genderqueer or gender diverse client and make that assumption based on their gender assigned at birth. I think that can be highly problematic.
Thank you. So our next question is, when using the craft, do you ask parents to leave the room?
So yeah, that's a really great question. And I think it depends upon your treatment setting. So in some of the work that we've been doing with Chicago Public Schools, we've been able to work with their legal counsel to determine that we can implement the use of the craft model without parents present. Now, of course, there are other rules and regulations about confidentiality and reporting to clients and reporting to parents and caregivers and so on. But we were able to determine within that practice setting that we could use the SBIRT model and use those screening tools without a parent present. Now, depending upon setting, I would argue that the youth or adolescent is probably going to be more honest with you if they're alone with you rather than a parent sitting next to them or a caregiver sitting next to them. So I think it depends on your agency or organizational practices to answer that question.
Thank you. So we had a comment here. Someone said harm reduction language is no longer using the term detox, but we use the term withdrawal management.
Great point of clarification, and I appreciate that. That's something that I need to make note of and update on this presentation too. And you're absolutely correct.
Thank you. Just wanted to share that with you. Thank you for your comment. Another question is, have you seen an increase in LGBT people getting resources online since COVID?
Absolutely. Not only seeking resources online, but actually being comfortable with seeking resources online too, right? So in some of my colleagues and some of the organizations here in Chicago that we've been chatting with, there are folks that feel a lot more comfortable sitting within their home environment in receiving telehealth or telebehavioral health services. Now, caveat on that as well, some are not, because they're in unstable home environments where their parents are not accepting of their LGBTQ plus identity. They are living within abusive environments in which there may be interpersonal violence or domestic violence situations where they're clearly not healthy and happy with receiving home-based care. It's important for them to get out of the home to receive that care. But I think it's an important ongoing practice that we are going to have to continue learning more about, both becoming experts at providing those services and care online, as well as ensuring that those services and care are available to everyone, both in urban and in rural settings, and not assuming that rural-based LGBTQ plus populations always want online telehealth or telebehavioral health services and care, and oppositely, that those living in urban settings that may have more access to in-person care may love and thrive and really want to receive online services and care, right? So again, I've said this a couple times today, know your client and patient population, understand best practices and the treatment settings and agency-based settings that you're working within, and ask the client. I think it's really important to be frank and engage them in a dialogue and discourse about how they can best be served. So I wouldn't want someone to assume that I really would love to receive my medical care online, or that I don't love getting my counseling online, right? So don't make those assumptions. Talk to your clients about options and about how you can best meet their needs.
Thank you, Michael. So we have two questions that are pretty similar, so I'm just going to sum them up. We have some folks asking if there's any research on the effects of transgender clients being on HRT, and if that would affect how you would assess their alcohol use.
Yeah, I'm not familiar off the top of my head with any existing research in that area. I'm going to make a leap here, but this is not clinically or practice informed, that it may have an impact upon their use. So, and again, that is a large leap, and I'm just speaking off the top of my head right now, so I want to make sure that listeners are very clear about that. But I think we need continued research in that area to know more, quite frankly.
Thank you. Our next question is, have you seen an increase in the need for referral to treatment with the increase of meth use over the last 2 years?
So yes, and it is very client-based. So we're seeing, and again, I'll speak from what I'm seeing and hearing here in Chicago and from colleagues across the US, ongoing trends with meth use, specifically amongst cisgender gay men, across race and ethnicity, which is really interesting. I think those trends have changed over time, moving from the white community into communities of color, but predominantly with amongst cis gay male populations compared to LBGTQ plus, from what I'm hearing.
Thank you, Michael. So our next question is, can you talk about the use of any of these screening tools in homeless shelters or camps? Since drinking is a social activity for many persons experiencing homelessness, it is difficult to measure how many drinks a person may have due to bottle sharing. And the person added, this includes other substances too.
Yeah, so it's a great question. I think this is a population-based question. I think this is where we need to think about modifying and adapting tools as well, right? So when we ask a client about their drinking or about their use, and they're sharing a bottle of this or that, I think I might want to ask a little bit more about how many sips they're taking, how frequently they're taking those sips, how many hours per day they're bottle sharing, and none of that was on any of the tools that you saw, right, in today's presentation. So that's one key area where I would say, know thy client population and know how to potentially modify it based on that population's behaviors. And I think that's a really, really important piece of information to convey, as well as ensuring the affirming piece, the cultural responsiveness piece as well, especially if you are not a member of a Native community, and ensuring that, again, you're using person-first language, affirming and affirming names and gender pronouns and all that type of affirming best practices as well. So yeah, that's a really great, almost mini case example of how you've got to take today's presentation and modify it to best meet the client's needs. Remember something I also said before, these tools are not the end all and be all. They are tools. They are tools that help us make the somewhat best determination for our clients. But your gut matters, your practice matters, your ongoing training and education in this area matters. It's a combination of efforts that I think really matters, as well as listening to your client, right? I think we often come from a perspective of knowing all and being able to know what's best for our client. And I think that's incredibly problematic. We are part of that puzzle in assisting our client in best meeting their needs with regard to screening for alcohol or substance abuse, and then the need for, if there is a need for, continued assessment, treatment, and care.
Thank you so much, Michael.